Hello, everyone. My name is Ryan, and I am here today on behalf of the marketing team with School Health. I'd like to thank you all for joining us today and participating in our webinar as we look at real-life scenarios that affect your hearing and vision screening, as well as when you're getting vital signs from students in your health clinic. We are very happy to have Kathleen King and Sunny Ochoa joining us today from the Healthier Kids Foundation. Kathleen and Sunny will be speaking on their experiences and procedures when providing hearing and vision screenings to school-aged children. We're also happy to welcome Dr. Joshua Wall, who is an assistant professor in the College of Nursing at the University of Utah. Dr. Wall's background includes emergency department, trauma, and thoracic ICU nursing. He also has 14 years of experience as a flight nurse for AirMed at the University of Utah, caring for both adult and pediatric patients. Given the extensive experience of all of our presenters, there's not really much that they haven't seen at this point. So as you listen along to their presentations, please be sure to add any questions you may have to the questions box in GoToWebinar. After these three experts have finished their presentations, we'll take some time at the end to answer the questions you submitted along the way. And also, when the presentations have ended and before the question and answer period, we will be drawing a lucky winner from those who are attending live, and the lucky winner will receive a Nurse Essentials Kit from School Health. Before I turn the time over to the presenters, I would like to review a few quick things about today's webinar. First, we will not be taking audio questions, but you can submit your questions through the questions interface in GoToWebinar. You can submit your questions at any time during the presentation, and we will begin to answer the questions after the 45-minute presentations are over. This webinar will be recorded and a link will be emailed to you for future playback. You can expect that email to come out sometime later this afternoon. Also, everyone who attends today's webinar will also be receiving a certificate of attendance for joining us today, and you should expect to receive that on the email that comes this afternoon. Lastly, if you are having technical difficulties with the audio or visual portion of today's webinar, please call GoToWebinar directly at 855-352-9003. Again, that number for GoToWebinar is 855-352-9003. And now we will turn the time over to Kathleen King and Sunny Ochoa.
Good afternoon. Thank you for joining us today. My name is Kathleen King. I'm the CEO of Healthier Kids Foundation. Just a little background for me, I was in high tech up to about 20 years ago, and I see my life as before BMT and after BMT. My youngest has an extremely rare syndrome. There's only 300 cases in the world, and I totally changed what I was doing after he went through his second bone marrow transplant. With me is Sunny Ochoa, and Sunny has been key to the organization. We could not have helped with 453,000 services without Sunny's help and her ability to be the backbone of the organization. Next slide. So just to go through a little of our background, we used to help all the children get health insurance. And now that 98% of children in Santa Clara County do have health insurance, we've focused on preventive health. And much of our work uses the screening camera and the OAE equipment. So we're going to talk about that today. But we really want to remove health barriers impacting the learning and life success of Silicon Valley youth. We believe in, when it comes to children, never sleeping and never giving up. I'm going to change the next slide for Sunny to speak to. Thank you, Sunny.
Thank you. As Kathleen said, I've been with Healthier Kids Foundation for about 8 years. Previously to that, I had worked with Catholic Charities in Santa Clara County for nearly 15 years. So my whole life and all my background has really been focusing on social services. Like Kathleen says, Healthier Kids Foundation has really connected the idea of a child's success in school back to their overall health. We're going to share some of our programs that we have, and then really be specific with our vision and our hearing program. Our first program that I'll talk about is appointment first, and that supports foster parents and caregivers in navigating the healthcare system and accessing medical and dental appointments. Children in foster care in our county and our state are required to have a dental exam and a medical exam every 6 months. We also have some educational programs that we offer through our county. One of those is 10 Steps to a Healthier You, and that's a 3-class series that teaches parents and caregivers healthy lifestyle tips for their children, talking about reducing screen time and swapping out sugary drinks for things like fruit-infused water. We also have some dental education programs, and our first one is called Smile First, and it's for children of all ages, parents and caregivers, and it really focuses on oral hygiene, dental care, and tooth decay prevention. We've had so much success in that program that we've actually been funded to teach the same principles to pregnant people, and we have a program called Pregnant First. And then we have 2 programs that focus on making sure kids are accessing Medi-Cal or Medicaid if they are eligible. In Santa Clara County, every child is eligible for Medi-Cal regardless of documentation or income. And so we have a program that reaches out to families just to enroll kids. And then we have a program called the Baby Gateway Project, and that enrolls newborn babies into Medi-Cal right after birth at bedside with mom. Then we have our 3 screening programs. We have Vision First, Dental First, and Hearing First. These 3 programs take place throughout our county and the surrounding areas. We screen in preschool settings, family resource centers, Head Start classrooms, and engage grades TK, kinder, 2nd, 5th, 8th grade in middle school, and 10th grade in high school. I did see a question regarding how do we get kinder kids to take part in the screening, and really we screen in groups. So kids come with their classroom, and when a child is scared and we have other children that are not fearful get screened, 9 times out of 10, that's going to drop the fear down for that child when they see, hey, it's not scary, my peers are doing it. All of our screenings are conducted at one time in the same room during a school day. So we request for a large room, may it be an extra classroom or a library on school campus. We set up our dental screening outside of the classroom with 2 dentists and 2 screeners, then 2 vision screeners inside the classroom, and 3 hearing screeners inside that same classroom as well. We ask to be away from the playground so we don't get a lot of noise. And again, it's just a request that doesn't always happen. And we prepare the students before they go into the room so they know what to expect. We work with school staff to create a schedule of the day and have the screenings timed out so each classroom can be seen in that day. We screen 1 school a day. 1 classroom of about 27 kids will take us about 20 minutes for all 3 screenings. We on average probably screen about 200 kids a day. There was another question regarding special needs students. We screen special needs students all school year long. And really what we do differently with them is we kind of give them a longer time allocation. We definitely ask for support staff to be there. So that may be a teacher. If a child has special needs and maybe has a one-on-one aide, we would want the aide to be there with them to make sure that they feel more comfortable. We explain what we're going to do with them. And sometimes maybe we can only have 1 child in the screening at a time so they're more comfortable. So we'll do that. And also we never force a child to be screened. If they're scared, then we would just let it go. And we are willing to come back and send a screener at a later date for our vision and our hearing screenings. Something that also helps in the process is that we receive what we call a roster from the school district before our screening happens. We also call this our student level data, and we upload that information into the spot camera and into the OAE hearing device. And we'll talk more about that when we talk about each program. But that really helps us stay organized when we're screening that entire classroom. Another thing that we do, especially for small kids, is we make name tags. So we'll have staff make name tags and drop those off before we screen the kids. The teachers will put those name tags on the kids. So when we go to screen them, we ask them their first and last name, we double check the name tags, and then we're already going to find them in that device. So we're not having to sit there and type their name in before or like while that child is there waiting to be screened. Again, like I said, Kathleen's going to talk a little bit more about our student level data and how we collect that and even present it and even give it back to the schools. Something that's really unique about our services that we follow up with every child that has a vision, dental, or hearing issue. We are going to assist those parents to make sure that they are accessing those appointments, and we're going to follow the family through until that child receives glasses, receives dental treatment, or receives hearing treatment. Next slide, please.
So we have currently, as of a few days ago, screened over 159,000 screenings. Not all unique children in the last 9 years. Some children have repeats in there, but 159,000 screenings. On average, the referral rate for before the pandemic every year was 14%. 14%. This last year, we screened 21,000 children, and it caught us by surprise that our screening referral rate was up 19%. Some believe it's screen time, not wearing glasses, etc. We can screen through glasses, but many children coming back to school were not wearing glasses. And so far, we've put 9,700 children in glasses using their own health insurance. About 60% that get a referral went to the eye doctor, and about 88% of those received glasses during their appointments. Next slide, please.
Thank you. In many of the schools, we actually work with the school district nurse or the school nurse. We will conduct the spot camera test, and then if a child doesn't pass, they will then do the acuity test with the child. And so that person will also be in the room while the other two screenings are happening. For us, the device has been, really great that kids that are not verbal can also be screened. A couple of our kind of tricks of the trade that we learn along the way, especially with small kids, if they get a refer. So we always say either pass or referred. We never say pass or failed. So if we do get a refer, we will actually screen the kids 3 times to make sure that they are facing the camera straight and that their eyes are straight. If you haven't used the spot camera before, this is what we call the result sheets or the vision screening summary report that comes out of the camera. We print this out and we send 2 copies back, one that will go to like the school or the school district and one that goes to the parent. This is only in English, but it's really great because it's so visual and shows the child's potential condition. Even if the parent doesn't read English, they can very definitely see that there's something going on with their child's eyes. And we encourage parents to take this form to the optometrist with them. So we send this form back, like I said, and on the back of it has a list of referrals for optometrists, and we'll share that in a minute. But we export this out, and some of the school districts also take the raw data that comes out of the spot camera and uploads that to the child's like online file. The little owl that you're seeing over here to your right is Ava the Owl, Be Wise to Your Eyes, and it's a book that we wrote about 7 years ago that we've distributed throughout the county that encourages parents to have their children's eyes checked, and then also encourages kids to wear their glasses. Next slide, please. So on the back of that vision summary report, you're going to see a list of optometrists. These lists of optometrists take one Medi-Cal and private insurance. We're going to tell the parents the days and times that the offices are open, and that's really important for working parents, especially if they need evening or weekend appointments. And then it also has the office's language capacity and the age that the office will take for children. Some offices will not take really young children because it is hard to complete a vision exam on really small kids. But this really helps parents kind of fit what best works for them. We have a group of parent advocates that just follow up on our vision cases. So any child that has a vision issue after using the spot camera, we call their parents. We make sure that child has health insurance. If they don't, we assist them in accessing health insurance. and then we find them an optometrist that works best for their families. Next slide, please.
So pertaining to the OAE equipment, we have screened we have had 99,000 screenings occur. We screen the children, as Sunny said, and for those that get a referral, we come back 6 weeks later to screen again. We want to rule out viruses, flus, etc. Often some schools, the nurses decide they also want to do the tonal hearing screening, but they do it only on those children that receive a referral from us. So up until the pandemic, the average referrals was 5-6%. 2% had already were receiving regular care. 15% were treated by their pediatricians to rule out fluid in the ears, need for adenoid tonsil removal. This last year, we screened 21,000 children, and the referral rate was significantly lower. We are assuming that is due to children wearing masks and being a lot healthier than they usually are. We have found children that need hearing aids, and we've helped with them getting their hearing aids and further follow-up. Next slide, please.
This is the referral sheet, which we call it, that is exported out of the OAE machine. The way the screening works is just like you saw in that last picture. A probe goes in a child's ear. That probe goes off at 5 frequencies, and the inner ear vibrates back if it picks up those sounds. If it misses any of those 5 sounds, it's going to go off again and vibrate back again. You will see on that top section of this referral sheet, it says that that child is referred, and the frequency lines have like a gap. And then below it, the child that has passed, those lines are closer together, so that inner ear is not picking it up. Like Kathleen says, we go back for this screening 2 times. And in between that time, our parent advocates are calling the parents, letting them know that we have found that their child may have a potential hearing issue. And at that time, that's when we're going to find out, right, if that kid has a cold or not. Also, we could find out at that time, well, maybe a parent is going to say, well, my child didn't pass their newborn hearing screening, but I didn't know what to do after that. Another thing that's great about this machine is that children do not have to be verbal, and they don't have to react to it. I have a 5-year-old son, and so we got ready for kindergarten this year. And when I was with the pediatrician, I said, oh, I definitely feel like he has selective hearing. And he has done this test before, and he's passed it. And sure enough, when me and my husband were sitting in the office doing the tonal with him, he was like looking at us, like, do I raise my hand? Do I not raise my hand? Do I raise my hand? Do I not raise my hand? So this is definitely works really well for small kids. You'll see here, Emma the Elephant, Good Hearing Helps You Work and Play. And that's another book that we created that we've distributed out through our county. If you're interested in any of these books, please shoot us an email. We'd be more than happy to send them to you and allow you to print them and out yourself and distribute them to your schools and your community. But this, again, is really a book for parents to read with their children and talking about the importance of checking your ears and following up with that and getting any type of hearing care you needed, including hearing aids. Next slide, please. Oh, this is our back of our referral sheet. So that hearing referral sheet is going to get sent home, and this is what the back of it looks like. So it looks different. It's not a list of doctors, because a child has to go through their PCP, and then the PCP will then send them on to audiology and ENT. So this is basically explaining what we have found, letting the parents know that we're going to call them and we're going to follow up. So we're going to follow that same process. We're going to make sure that that child has health insurance. If they don't, we're going to assist them in accessing it, and then we're going to find a doctor that works for that family. Kathleen doesn't share this often, but we will help advocate for families to receive hearing aids. She is fearless, and she will find donors to help families that their insurance don't cover hearing aids. A lot of health insurances don't pay for hearing services, and it's very expensive. So we have had situations where we've reached out to our group of donors that will help families make those purchases. So we are also advocating for family in helping them find a solution to this health issue as well. Next slide, please.
So I'm not going to spend too much time because we're running short on time, and I want Sunny to talk about her story. But we do use Salesforce for all our data. I actually looked, we're at 457,000 services. We can backtrack every single result in our database. We've never had a security breach. And all the data is uploaded to us. We upload it into the equipment. That's why we can do the screening so quickly. And we download the results into the school records for the schools if they want to do it that way. So this is the data we collect. So I'll skip to the next slide.
And we will share that template with you guys if anybody wants to use it to upload into the camera. So my story is I was already with Healthier Kids Foundation before I had my son, but that first picture on the left is us at a community event, and you can't really see, but that little hand holding the camera is actually a bunny rabbit. We were at an Easter event, and I brought my son so we could take some pictures for social media. And so as we were taking these pictures, they were like, Sunny, do you really want to have your son get a vision screening? And I was like, yeah, let's do that. And much to my surprise, we found that he had a very severe stigmatism. One eye is a negative 6.5, and the other one is a negative 5.25, and he was only 13 months old. Very soon after, we got him his first pair of glasses, and I never had vision issues. I never wore glasses. I never saw anything. And the relatives that took care of our son while we were at work, nobody ever thought that he had a vision issue. And fast forward to today, he's a happy, healthy, thriving 5-year-old who wears his glasses every day. He wears them from the time that he wakes up until the moment that he goes to bed. And they are life-changing. Our son is very advanced academically, and that 100% has to do with him wearing glasses. And really early on, when we first started this program, we screened kind of everywhere. And we had screened at an after-school program. And an after-school program coordinator came to me later. I was doing a community presentation and said, Sunny, I had this kid who was in 3rd grade, and he was a knucklehead. He would never sit in his chair. He always messed around, never did his homework, bugged other kids. And she said, you guys screened him and you guys got him in glasses, and he's a completely different person, And we learned so early on how specifically just putting a kid in glasses could change the trajectory of their whole entire life. And I feel very personally attached to this now. Not only did I help Kathleen develop this, but now I have a little boy, and I have a little boy of color, and he's spicy like his mom. And last week, a teacher actually referred to him as being spicy. And so I think if my son had that attitude and didn't do well in school academically, he could go down a very, very different path. But because my son is smart and has glasses and is going to be successful in school, right, we're gonna switch that spiciness up into some leadership skills. And so he's going to have a really different life, and he's not going to be called a knucklehead because we have set him up with these pair of glasses. So I think it's really easy. This device is so easy to give kids an opportunity. And Kathleen and I really thank you for inviting us and allowing us to share our stories and our success with you guys. Thank you.
And I will just add, my son's been in hearing aids since he was 6 months old. So between glasses, hearing aids, and adding in dental, we think they're critical for children's success. So this is how to get hold of us. And thank you very much, School Health, for asking us to do this. Thank you.
Thank you very much, Sunny and Kathleen, for that wonderful information. We have with us now Dr. Joshua Wall. Let me switch over to Dr. Wall, and you can take it away when you're ready.
All righty. There. Perfect. Well, good afternoon, everybody. My name is Josh Wall. I'm very excited to be here today. I want to thank Ryan Eborn and School Health for having me. I'm going to talk about vital signs, back to the basics. And this is something that as registered nurses, licensed practical nurses, CNAs, is something that we learn very much early on in our healthcare careers. And sometimes it's good just to go back to some of those basics, especially if we're maybe questioning, are we getting the vital signs right that we need? Are we using the equipment as it should be? Can we make that process any better? So why vital signs? Well, research has shown that when patients have any kind of deterioration, we can typically see signs of that change about 48 hours before an adverse event occurs. And a lot of that change comes in very subtle vital signs. Now that's obviously if we're doing sets of vital signs, maybe not just getting a snapshot, but knowing those trends can help us to keep an eye on patients and hopefully mitigate an adverse effect from occurring if we're monitoring those early on and consistently. Research also shows that medical errors account for a lot of issues in healthcare due specifically to inaccurate monitoring of vital signs or really the failure to notice those trends. So one of the key things I kind of impress upon my students when I'm teaching the basics of vitals is, yeah, you can look at a blood pressure, a heart rate, SAT, that's great, but it's not going to tell us a whole lot. We need that whole picture and looking at those trends. Are they getting better? Are they getting worse? What comorbidities do these patients have? And really making a conscious effort to look at those trends there. I don't know about you all, but when I have worked with kiddos and even adults, they're like wet little noodles. They may not want to get up, get in a comfortable position because they're either scared or they just don't want to be there. So I've found, and I've had children and adults in very precarious places, the bed's in the emergency department, in the back of a helicopter, out on scenes of accidents, and been in all sorts of positions. But I found that positioning can really be to your favor, work in your favor when you are assessing vitals, especially blood pressure and heart rate. Research has shown that if a patient's back and feet are supported and they sit with their legs uncrossed, so ideally just in a chair sitting up, we get more accurate vital signs. And it's shown that if our back and feet are not supported, we can have as much as a 6 millimeters of mercury change in our systolic blood pressure. If legs are crossed, not as much, maybe 2 to 4 millimeters of mercury. But if we have an unsupported arm, so rather than just have a child rest their arm there, or they're just holding it up, we could see as much as 10-point change in their vital signs. As far as blood pressure sites, the most common place we always get is just on the brachial artery there. But I have found there's instances where you can't get to an extremity to do that. Maybe there's an obstruction there. Maybe that child or patient doesn't have an arm on that side. So we need to look at backup places to get those blood pressures. While I've never done a radial artery blood pressure itself, it is totally possible to do that. It's just a matter of sizing the cuff directly or correctly around that arm and ensuring that we're auscultating that radial artery. I have done it many a time on the popliteal artery behind the thigh. Good place, just a little precarious place to try to get to. We can also do it down on the pedal pulse as well. So, there are options, and we're not limited just to the right or left arm. So depending on the situation we're in, if we come upon a child or a patient, and that might not be the ideal spot, there are other places that we can do that. Kind of along those lines too, in my career being in emergency nursing, a lot of times we don't have the luxury of having that equipment readily at our hands. So when I've approached patients before, and I just want to get a good quick snapshot of how they're doing, just palpating a radial pulse can actually tell us quite a bit. Research has shown that if we have a strong radial pulse, our systolic blood pressure is at least 80. Now, a BP of 80 over something isn't that great, but it's enough to know that we are both perfusing our brain and our kidneys. If we don't feel anything there, we can also feel for a femoral pulse. And if we feel a strong femoral pulse, we can have a systolic just roughly around 70. Again, not great, but at least we know we're perfusing to the core. And if we are in a situation where we can't feel radial, can't feel femoral, a carotid pulse is always something to check too. And if we do have a strong carotid pulse, we do have a systolic pressure of at least 60. So again, not the most accurate, but if you're in a situation or maybe have multiple patients and you just need to do a quick triage on them and say, are you perfusing? This is a way that you can do that as well. I found too, I get too reliant sometimes on sat monitors to get my heart rate. So especially if somebody tends to have a variable heart rate or comorbidity, I find it better just to put stethoscope on the chest and auscultate at the apex. Especially if kids, especially the little ones, are very tachycardic, it's good to get that for that full minute, just to ensure that we're getting an accurate representation of what that blood pressure and our heart rate is. Kind of the same thing for respirations. Kiddos don't like to be touched. Some adults don't either. So there can be a lot of variability in respiratory rate. So, if you have a calm patient and they appear to have a normal respiratory pattern, yeah, you can do respirations for 15 seconds and then multiply it by 4. But I found with kiddos, just because there is so much variability, it's really better to do it for a full 60 seconds. Now, the other problem I run into is, what does somebody do the first thing they see that you're watching them breathe? They're going to breathe different. So I try to be sneaky and you just check their pulse and pretend like I'm doing it for a while, just to ensure that they're not going to watch me watch them and might give me an erroneous rate for the respirations. Another concept that I learned as a flight nurse kind of later on was the concept of O2 latency. And so in essence, what this is, if you think about taking oxygen in, and if we're monitoring sats on a finger, on a toe, on an ear, it takes time for that blood to circulate to that extremity. Well, there have been times, and in critical care, obviously, we're more worried if we're putting an airway in or trying to give supplemental oxygen or medication. But a lot of times, it can be a little unnerving where you're providing something, when you put a breathing tube in, or you're giving albuterol treatment to a kid who having an asthma attack, and you're watching their sats, and all of a sudden they just tank. Well, the child may look okay, but their sats are down in the 60s. Well, that's what we call that O2 latency, because by the time that oxygenated blood can finally get down to that extremity, there's going to be a little bit of a latent period before we can actually see it working. And the research has shown that can take up to 2 minutes, and that can be a very long 2 minutes, especially if we have a patient who is critically ill. So, I try to teach medics out in the field, if they're intubating somebody or if you're providing a treatment, rather than kind of have a knee-jerk reaction, oh, we need to pull the tube, or we need to give more medication, we need to check the oxygen, give it a little bit of time. If you've ensured you followed all your steps to provide that treatment, sometimes it's just that O2 latency that can take a little bit of time. And then you throw in, hypotension or bradycardia, it might take even longer to get that signal down to whatever extremity that we're monitoring. Temperatures, I still remember as a kid using the old mercury thermometers. Thankfully, we don't have those anymore. Digital thermometers are, in my experience, the best. Getting an oral temp is probably the easiest, but really any way you get a temp, we just need to make sure that we're doing it accurately. Oral is obviously the easiest, but there are times where that can't be had. Tympanic temp, that's what we used to carry on the helicopter because we could get to somebody's ear and sometimes not their mouth. Axillary temps, especially for kiddos, I think that's a good option because it's least invasive. But unfortunately, that has the downside of being one of the least accurate types of temps. The temporal artery, the little laser on the forehead, gives us a pretty good temp. But ultimately, the most accurate temperature for a true core temp is a rectal temp. Now, I realize we're probably not in situations that you're going to be doing that, but just keeping in mind that regardless of the method of taking a temperature, there's going to be a little bit of variability in that. So whether you're doing the temporal artery or an axillary temp, oral, tympanic or rectal temp, if you have a temperature in one, you need to account for what that might look like. So again, just knowing that if you're taking an oral temp, yeah, it's going to fall right in the middle. But if you have a temperature and you're only doing an axillary temp, it possibly could be higher than it really is if you were to do it, oral or rectal in the ear. So just something to think about, regardless of the method of where you get that temperature, just ensuring that you're knowing to account one way or the other if it's going to be a little bit higher or a little bit lower. Pain, we always teach, is the fifth vital sign. I found in my practice, kids are very stoic. In fact, they're almost more stoic than some adults. So it can be hard to elicit a reaction from kiddos sometimes, or to get them to tell you what their pain is. So I've always found that the face scale is a really good way to do that. And it works great for adults too. Literature's shown that the faces are actually the most accurate and easy to use for children between the ages of 3 and 8, because they might not be able to really verbalize what their pain is, but just by pointing to that, it can be very, very helpful. Interesting too with pain, a lot of pain goes untreated, unfortunately, and the literature shows that there is disparity among race in patients as well. In fact, they've shown that non-white patients, even children, often have less pain medicine given to them and less pain assessments than their white counterparts. So something to think about, that we're being equitable across the board and assessing our pain equally for our students, and doing it in a method that's going to give us the best result in order to treat that patient. Other little tips and tricks that I've found over the years, and you probably had in your practice as well, it really comes down to, if you're going to maximize getting good vitals, you need to have good equipment that fits right. So really the right equipment. One of the biggest things that I've noticed as far as vital sign disparities is proper cuff sizing. So as you can see, a little kid here, it doesn't do a whole lot of good to have a big cuff. In fact, I can still recall once an EMS unit brought a kiddo in and they were just freaked out because they were so hypotensive. Well, I look and they had a thigh cuff on that kiddo's arm. So once we changed that cuff out, we actually got a more accurate reading. So things to remember, if a cuff is too small, we're generally going to get a higher reading. And if that cuff is too large, it's going to be a little bit lower. So always good to measure that. And I always teach my students the 80-40 rule. So the length of that cuff bladder should circle roughly about 80% of the circumference of that patient's upper arm. Now, again, if you're going to be taking it down for the radial artery, on the thigh, for the popliteal artery, or down for the dorsalis pedal pulse, we need to adjust for that a little bit. But nowadays it's great because cuffs come in, adult, small adult, child, infant, neonate, and thigh cuff. And the 40%, it's the width of that cuff bladder. So that should be about 40% of the patient's upper arm circumference, about midway between the olecranon of the elbow and the acromion process coming off the shoulder. Again, I've seen in my practice some very subtle changes with different types of blood pressure cuff sizes, but I've actually seen some very significant ones. So, if you have the right equipment and can take the time to size that up accurately, you're going to get the most accurate vitals in order to get those good trends and see how your patients are doing, not only in that moment in time, but looking at their trends as well. That's really all I have. Like I say, vitals are pretty vital. We're all good at them, but just a couple things that I've seen in my career. And I appreciate the opportunity to be here today. And that's my contact information if anybody has any further questions. But I will turn the time back over to Ryan.
Wonderful. Thank you, Dr. Wall, for that wonderful information. Very, very educational. I had mentioned earlier that we are going to be doing a drawing for the Nurse Essentials kit, and it looks like we have Tamara from California, who is live with us now. And Tamara, congratulations, you are the winner of the Nurse Essentials kit. We will be reaching out to you directly to get shipping information so that we can make sure to get this right out to you. And with that, we can jump right into our Q&A. If the presenters could bring their cameras back on. It looks like we've got quite a few questions that have come in here for both Kathleen and Sunny, as well as for Josh. And let's see, let's get started. Let's see, I've got here a question from Denise. Denise asks, if a child is tested with the spot vision screener and it says problem focusing, I understand you test 3 times. If it still gives this reading, is this a referral? And we have a couple of different questions. We've got a question from Stacy that is asking essentially the same thing. So we've screened a child 3 times. We are still getting a problem focusing error. Do you consider that a referral?
We would also try testing, it's called mono, and it's where it tests one eye at a time. I would try that, and then yes, we would consider that a refer, and then we would still send that off to the parents, and then also make a note for our case management team to follow up with that parent and let them know that the test was not able to be completed correctly.
Okay, wonderful, thank you. I've got a question for Dr. Wall. Ellen is asking, what is your opinion on auto cuffs?
That's a good question. I think for just generic everyday use, an auto cuff is fine. My mother-in-law has one that she just gets on Amazon that can monitor pressure that has good results. And I've done side-by-side comparisons, and as long as it's a reputable brand and it doesn't wore out, batteries are good in it, I think they're okay. I mean, nothing's better than doing a manual pressure, but a lot of times we don't have the luxury of doing that. So I think some of those automated cuffs, they're good for what we need.
Okay, wonderful, thank you. Question, I think this is relating back to vision and hearing screening for Kathleen and Sunny. How do you get the schools to share their class lists, and does FERPA get in the way? This is a question from Rachel.
Sunny, you want me to take that one?
Yes.
We make sure we only work in districts where the superintendent supports the work we do. So there, in our county, there's 31 districts, and we work in the underserved areas where the superintendent is very supportive. We do MOUs. The MOUs cover FERPA. They say we can only use the data for specific needs, and we are very, very careful not to use it for anything but the referrals and care to physicians in the area. And if anyone wants, we can forward an MOU. It's kind of nice to have them. I will say that we've also we do not do consent forms, we do opt-out forms. And for many of the districts we've worked in a long time, they just put us in the handbook, and it states to the parents how they can opt out if they do not want to have the vision or hearing screening from us.
Okay. All right, I've got another question here from Annie, who says that her state requires a 20/20 acuity reading result. When you're using the spot vision screener, how do you convert those results? So this could be either for Kathleen or Sunny. We also have Mary Ellen, who is our vision and hearing expert. She's on the line, so she may have some input for this as well.
Sunny, I'll just say we don't convert. There isn't a good way to convert. We actually took a bill to the state through the legislators to allow us to use the screening cameras, but we didn't realize that we also needed to change how the data went in. So for those districts, there's that they feel that they have to give that data, they will screen those that we show a referral. So that 15 to 20% that have a referral then go through the acuity test, and that data gets turned in to the state. Sunny, did you want to add anything to that?
No, that was what I was going to say.
Yeah, I was just going to agree that if you have to do an acuity test, you should do it with a standard eye chart of some sort and use the spot vision screener for the other methods that it's good for.
Okay.
I will say that it has helped the nurses. You know, we only have one nurse per every almost 2,900 students. So it allows the nurses to focus on that 15 to 20% that get a referral from us.
Okay, wonderful. Thank you both. Thank you all. Question for Dr. Wall. What does it mean to calibrate a cuff? Is that done for everyone or for each individual? This is a question from Ellen.
Usually, like the bigger brands that you see in hospitals and clinics, they come calibrated. And even the ones that you can buy off online are calibrated. I can't really speak to the actual process of doing that. But I know that most ones that you can buy, especially, I think the Welch Allen through the school health, those come calibrated. And then they have, after a certain amount of uses, they need to be recalibrated just to ensure that they're getting the right readings for those patients. But as far as the overall actual calibration process, I unfortunately can't speak to that.
Okay. All right, thank you. We have a question here from Leslie. Leslie is asking, do you have suggestions for how to get accurate OAE readings on a very young child that may have difficulty holding still for the period of time needed? Leslie also asks, how do you decide what size or type of probe cover to use for a particular student? She remarks that she struggles with getting the probe in the correct location and then ensures that the child holds still long enough to get an accurate reading?
The device we have, one, it tells you if the probe is incorrectly or not, and it won't even start until the probe is incorrectly. And the second part of that is the way that we started is that we would buy like the full kit that had all the different sizes and kind of based on like the age of the child or the size of the child. And really, I think we've done this for so long that you kind of can look at a kid's ear and then know what probe to put in like on for them. And they are expensive, and so sometimes you might put in, use one that's too big, have to throw it away, and then get a smaller one. But the device has been really great because it tells you if it's incorrectly or not. Kathleen, do you want to add to that?
No, I don't think so. I think our staff have been doing it, 21,000 a year. They get pretty good at it. But they don't force it. They work with the child, and sometimes they have to let that child go and then come back a little later. So I think that's part of it.
Okay, excellent. I've got another question from Caitlin. Earlier, Kathleen and Sonny, you referred to a 19% increase that you had seen in referrals. What was the biggest thing that you were seeing that led to that 19% increase?
So before the pandemic, we always ran about 20 to 25,000 screenings a year, and it was always a 14% referral, just very consistent. And that includes children that may not be wearing their glasses that day, but very consistent. After the pandemic, we've been running, surprising to us, 19%. So that's a fairly significant increase. It's probably a combination of children not wearing glasses, not used to wearing them at school, haven't been into an eye doctor in a couple of years. And then there's some studies out recently that say the amount of sun you get can affect whether you have astigmatism or end up farsighted. And so there's significant data on that, or excuse me, nearsighted, can't see as well far away. And just more screen time. That's our estimate.
Okay, wonderful, thank you. I'm just getting a note here from our team here at School Health, going back to the question on calibrating cuffs that Dr. Wall was answering. Just to let everybody know, if they are in a situation where they need a cuff calibrated, we do have a service center here at School Health, and we can help you with those calibrations. So if you need assistance in getting your equipment calibrated, please reach out to us. That goes for hearing equipment as well. Our service department can handle that. We are authorized by Welch Allyn to service these machines. So just connect with us here at School Health, and we can provide that assistance for you.
Hey Ryan, can I add to that too? On the equipment we buy, it lasts forever. I mean, this equipment is amazing how well it lasts. But we always follow up on the preventive maintenance. We're very, very set on doing that. But the equipment just, I mean, we screen thousands and thousands each year for every piece of equipment we have. And we got our county clinics to buy this vision screening cameras as well.
Was that like a grant situation, Kathleen?
Yeah, they had a grant, and sometimes people like to buy you capital. A lot of people want to buy capital, and so the county had a grant, and we told them that's what we thought they should use the funding for.
Definitely, that's excellent information. Thank you for sharing that. As long as we're on the topic, Mary Ellen, I know that you have some experience with grants as far as buying capital equipment as well. Is there any information that you're able to share with us if someone is looking for funding for purchasing any of the devices that they may need?
So I know right now there's a lot of government funding out there based on the COVID and pandemic, ESSER funds, and the American Rescue Plan. As far as vision and hearing go, those are both funds that allow you to buy assessment tools, evidence-based assessment tools, and the Spot Vision Screener and the Welch Allyn OAE hearing screener, along with other hearing equipment, are all fall under being evidence-based tools for assessment. And so you might find by looking at what your state is allowing for, or your district or county, from those fundings to be able to fund some of the products that have been talked about today.
And I'll add, we went after Rotaries, Rotary clubs. Love this capital.
Thank you, Kathleen. Thank you, Mary Ellen, for that information. I've got, looks like another couple of questions for Dr. Wall. First, how do you have the arm at heart level for checking blood pressure? I have always rested the forearm on the desk.
That works, because if you think back to the anatomy and the phlebostatic access, if it's around, the fourth intercostal space, whether it's up on a desk a little bit off to the side, it's pretty accurate. You just don't want an arm above the head or an arm below the waist, but anywhere in that area, you get a fairly similar reading for either one. So it's really, if that's the best position that a child is most comfortable in to get that vital sign, then that's fine.
Okay, wonderful. Thank you, Ellen, for that question. Question here from Amy for, again, Dr. Wall. When using automated cuffs, is one arm better than the other for placement? Should the arm be placed across the chest or on a desk?
Again, I think either one. I want to say it's an old wives' tale that if you put the cuff on the left arm, you'll get a little more accurate because it's close to the heart. But really, unless there's some perfusion issue like you'd see in an adult, or maybe somebody that's had a mastectomy and lymph node removal, really either arm's fine. If you do happen to get really odd readings on one or the other, that might warrant some concern for follow-up. But really for kiddos, either arm and any position of comfort that's within that range of either to the side or up on a desk should be fine.
Okay, and then one more from Alice. Alice says that she's having a difficult time sometimes getting a diastolic pressure in small children. Do you have any suggestions for her?
I wish I did, just because it's so variable from child to child. If you're doing a manual cuff or even automated, I think cuff size is probably going to be the best bet. And there's times though it's just hard to get a diastolic on kiddos. I'll try to do even maybe a couple repeat vital signs, 2 or 3 in a row, and average them, especially if I'm only hearing a diastolic, I think, on one or the other. But again, worst case, if you're just concerned ultimately about, is this patient perfusing, even if you can just get a systolic, they are perfusing, and unless that kiddo has some kind of congenital heart issue that would indicate diastolic dysfunction, usually you're okay, at least by having a systolic pressure. But that's what I recommend, because I don't know if there's really a surefire way to ensure that you'll get it on a kiddo. So.
Okay, sounds good. Thank you. Thank you, Dr. Wall, for that information. Looks like we are getting short on time here, so I want to just go over a couple of quick things. I've seen a number of people ask if this webinar is recorded, and yes, we are recording this. We will send out a copy of the recording to the email address with which you used to register. That email will come out later this afternoon. We will also include a copy of your certificate for attending today. We've also received permission from the presenters to be able to include the slides on those follow-up materials. And so you can look for the presentations of the slide decks on those materials as well. As we're exiting the webinar today, you will see a survey that pops up. I would invite you to take just a few moments. There's only 4 or 5 questions on the survey, but if you wouldn't mind taking a few moments to give us some feedback on what we've done here today, things that you liked, things that perhaps you didn't see that you would have liked to have seen, that will help us improve these presentations for the future. I'd like to thank Kathleen King, Sonia Choa, and Dr. Joshua Wall for joining us today. I know that your time is valuable. You have really given us some great information. I very much appreciate you taking the time to spend with us here today. And with that, I will go ahead and close the presentation.
And thank you, Ryan, for your help. I appreciate it.
Absolutely. Very welcome.